A unicornuate uterus is a congenital uterine anomaly in which only one half of the uterus fully develops, leaving the organ with a unilateral horn-like appearance instead of the typical pear-shaped configuration. Think of the normal uterus as a symmetrical fruit. The unicornuate variant looks more like a banana or a single unicorn horn. The condition results from incomplete formation of the Mullerian ducts during embryogenesis. Clinically, many women are unaware of this anatomy until they encounter reproductive difficulties or undergo imaging for unrelated reasons. The structural limitation can influence how the endometrial lining expands, how embryos implant, and how the uterus accommodates a growing pregnancy. The uterus originates from the paired Mullerian ducts, which normally fuse longitudinally to create a single unified cavity. In a unicornuate uterus, this fusion is incomplete. One duct matures into a functional hemicavity, while the contralateral duct either fails to develop or remains as a rudimentary, non-communicating remnant. The precise trigger for this developmental mishap is not fully understood. Research points to stochastic genetic variations, possible disruptions in signaling pathways, for example, WNT/HOX genes, or environmental insults during the 6 to 12-week gestational window. Importantly, no maternal behaviors, medications, or lifestyle factors have been proven to cause the anomaly, underscoring its classification as a random embryologic error. Because only one Mullerian duct contributes to uterine formation, the resulting cavity is narrower, often asymmetrical, and may be misshapen. The endometrial surface area is reduced, limiting the space available for embryonic implantation and placental development. This can lead to suboptimal vascular supply, increased tension on the myometrium, and a higher propensity for malpositioned implantation, for example, low-lying or eccentric placenta. Clinically, the analogy of parking a car in a one-bay garage illustrates the mechanical constraints. The embryo may struggle to find an optimal niche, increasing the risk of early loss or compromised growth. Additionally, the contralateral side may harbor a rudimentary horn that, if functional, can generate cyclical endometrial shedding without an outlet, potentially causing pain or ectopic gestation within the horn. Unicornuate uterus is a rare congenital anomaly, detected in roughly 1 in 4,000 to 1 in 5,000 women of reproductive age. The true prevalence may be slightly higher because many individuals remain asymptomatic and never undergo imaging. The condition appears across all ethnicities and socioeconomic groups, with no gender-specific predisposition, as it affects only those assigned female at birth with a uterus. Most epidemiological data come from retrospective studies of women evaluated for infertility, recurrent pregnancy loss, or obstetric complications. The clinical spectrum ranges from complete silence to pronounced reproductive difficulty. Many women discover the anomaly incidentally during routine pelvic ultrasound or laparoscopy. When symptomatic, the most common manifestations include dysmenorrhea, painful periods due to uneven uterine contractility, abnormal uterine bleeding, often irregular or heavy on the side of the functional horn, infertility or subfertility, recurrent first trimester miscarriage, and a predisposition to preterm labor or malpresentation, for example, breech in later gestation. Some patients describe a vague heaviness or pressure localized to the lower abdomen on the side of the horn, akin to carrying a small backpack on one hip. Diagnostic workup typically begins with transvaginal or transabdominal ultrasound, which can reveal the unilateral horn, its thickness, and the presence or absence of a rudimentary counterpart. If ultrasound findings are equivocal, magnetic resonance imaging (MRI) offers superior soft tissue contrast and multiplanar capability, allowing precise delineation of uterine morphology, myometrial thickness, and any associated renal anomalies, such as renal agenesis, which occurs in up to 30% of cases. Hysterosalpingography, HSG, can demonstrate a unilateral cavity with a single tubal silhouette, confirming functional outflow. In complex cases, 3D ultrasound provides volumetric reconstruction that aids surgical planning, especially when a rudimentary horn is present. Unicornuate uterus is categorized based on the presence and characteristics of a contralateral rudimentary horn. Class 2, a communicating rudimentary horn. The rudimentary tissue has an endometrial lining that connects to the main cavity via a narrow canal, allowing menstrual flow but posing a risk for obstructed gestation. Class 2B, non-communicating functional horn. The horn contains endometrium that sheds cyclically without a channel to the main cavity, leading to hematometria, dysmenorrhea, or endometriosis. Class 2C, non-functional rudimentary horn. Lacks endometrial tissue, generally asymptomatic, but may still be a site for ectopic implantation if it contains a functional ovary. Class 2D, no rudimentary horn. Pure unicornuate uterus without any contralateral tissue. Each subtype influences clinical management, especially decisions regarding surgical excision of a problematic horn. Management is individualized according to symptom severity, reproductive goals, and anatomical specifics. Asymptomatic women with a well-functioning unicornuate uterus may simply be observed, with routine obstetric monitoring in future pregnancies. Rudimentary horn excision is recommended when the horn is functional, causing pain or menstrual obstruction, or when it poses an ectopic pregnancy risk. Laparoscopic or robotic approaches are preferred to minimize morbidity. Fertility assistance, for example ovulation induction, intrauterine insemination, IVF, may be employed for those experiencing subfertility. IVF can bypass tubal factors and improve implantation odds. Pregnancy surveillance includes early transvaginal ultrasound to confirm intrauterine location, serial growth assessments, cervical length monitoring, and planned cesarean delivery at 37 to 38 weeks to avoid labor-associated complications. Hormonal therapies, for example progesterone supplementation, may be used prophylactically in women with a history of miscarriage, though evidence is limited. Counseling about the increased likelihood of preterm birth, malpresentation, and the need for a planned cesarean section is essential. Since the unicornuate uterus arises from an embryologic mishap that occurs before a woman's birth, primary prevention is not feasible. No preconception interventions, lifestyle modifications, or environmental exposures have been identified that reduce the incidence. However, secondary prevention, early detection, and appropriate management can mitigate complications. Prompt evaluation of unexplained dysmenorrhea, infertility, or recurrent pregnancy loss with imaging allows timely diagnosis and planning. Overall, the reproductive outlook for women with a unicornuate uterus is favorable when the anomaly is identified and managed appropriately. Approximately 40 to 60% of affected women achieve a live birth, with higher success rates after removal of a problematic rudimentary horn. Risks that persist include a 2 to 3-fold increase in first trimester miscarriage, a higher incidence of preterm delivery, approximately 30% of pregnancies, abnormal fetal lie, especially breech, and intrauterine growth restriction. With vigilant obstetric care, early ultrasound confirmation of fetal location, cervical competence assessment, and elective cesarean section, the majority of pregnancies culminate in healthy neonates. Contemporary investigations focus on two main fronts: imaging refinement and genetic elucidation. High-resolution 3D ultrasound and pelvic MRI now provide detailed volumetric maps of uterine geometry, enabling surgeons to plan minimally invasive horn excisions and obstetricians to anticipate obstetric challenges. Studies comparing conventional 2D ultrasound with 3D reconstructions, demonstrate a 20 to 30% increase in diagnostic accuracy for detecting communicating versus non-communicating rudimentary horns. On the molecular side, whole exome sequencing of women with Müllerian anomalies has uncovered rare variants in genes regulating ductal fusion, for example WNT4, LHX1, HOXA13. While causality remains under exploration, these findings hint at a polygenic predisposition that might someday allow pre-implantation genetic screening or targeted counseling. Additionally, experimental animal models using CRISPR-mediated knockouts of fusion-related genes are shedding light on the developmental timeline and potential therapeutic windows. Collectively, these advances promise earlier detection, personalized surgical strategies, and possibly future preventive genetics.